Hi guys, welcome back to my channel Obgyn Made Easy. Today I'll be discussing on preterm labor. Preterm labor is labor starting before 37 completed weeks, which is less than 259 days from the last menstrual period. Now, the lower limit of age of viability in developed countries is about 24 weeks, whilst in developing countries is about 28 weeks. So if a pregnancy is less than 24 weeks or less than 28 weeks, depending on which country you're in, this is considered as an abortion. Definitions. A pregnancy is considered very preterm if the gestation age is between 28 to 32 weeks gestation age. Extremely preterm is when it's less than 28 weeks gestation age. Low birth weight is less than 2.5 kgs. Very low birth weight is less than 1.5 kgs. Extremely low birth weight is less than 1 kg. Incidence. The prevalence of preterm labor is about 7 to 12% of pregnancies. About 25% of the cases of preterm birth are elective deliveries. This is a planned induction of labor. This planned induction of labor is usually for diseases like preeclampsia, intrauterine growth retardation, or maternal disease like diabetes mellitus or cardiac disease. Incidence is lowest at age of 20s but increases in teenagers and over 30 and in the first pregnancy. It's important to differentiate preterm labor from other conditions that mimic preterm labor like a urinary tract infection, bacterial vaginosis, or acute appendicitis. A diagnosis of preterm labor or any labor is made when there's regular uterine contractions of at least 1 in 10 minutes, cervical dilatation of more than 2 centimeters or 2 centimeters, cervical effacement, this is where there's thinning of the cervix, or a cervical length of less than 2.5 centimeters. However, you can only measure the cervical length using a transvaginal ultrasound, and where there's funneling of the internal os. Funneling of the internal os is where there's dilatation of the internal os. Suppose this is the internal os, this is the external os. Okay, and that's your uterus. So what happens is there is dilatation of the internal os. So this is the internal os dilating. And symptoms like increased pelvic pressure, where they'll present with lower abdominal pains, usually associated with uterine contractions, backache, and vaginal bleeding. By vaginal bleeding, we mean show. Show is the falling of the mucus plug, which can be mixed with some blood. Etiology. The cause of preterm labor is not known in about 50% of the cases, and a lot of factors contribute to preterm labor. Some of the accepted proposed theories in preterm labor are progesterone withdrawal. Progesterone is important in pregnancy in the sense that it inhibits myometrial contraction and also suppresses prostaglandin formation. But in preterm labor, however, progesterone decreases and oxytocin increases. So oxytocin, we all know that it causes myometrial contraction, which can lead to preterm labor. The other accepted theory is that there's premature activation of the maternal fetal hypothalamic pituitary adrenal axis. I'll talk about this just now. But regardless the cause of preterm labor, the end result is activation of the inflammatory mediators like cytokines. I'll talk about this just now. I'll come back to this diagram of etiopathogenesis. First, let's look at some risk factors so that you get a brief concept of what I'm going to talk about on etiopathogenesis. From your history taking, you should be able to gather some information that will tell you the risk of preterm labor occurring in this patient. Previous history of spontaneous or induced abortion. Previous history of preterm labor. This is because the risks that were there in the previous pregnancy might still be present in this pregnancy, which can result into preterm labor. Assisted reproductive techniques, low socioeconomic status, and poor nutrition. This is because this group is vulnerable to genital urinary tract infections. Maternal stress, low BMI, extremes of age, like teenagers and above 30 years, African American race. General risk factors of preterm labor: infection or inflammatory conditions. Infections like urinary tract infections, which are cystitis. Cystitis is inflammation of the bladder, and pyelonephritis. The organism we're worried about in urinary tract infections that cause serious infection in the neonatal period is group B streptococcus. This is because it causes serious infection like meningitis, pneumonia, and neonatal sepsis. Genital tract infections like bacterial vaginosis, sexually transmitted infections like chlamydia, gonorrhea, asymptomatic bacteriuria. Asymptomatic bacteriuria is where the organism is growing in the urinary tract, but then the patient does not present with signs and symptoms of a urinary tract infection. So the common genital tract organisms are beta hemolytic, beta hemolytic streptococcus, bacterioids, mycoplasma, and ureaplasma. Choriamnitis. Choriamnitis is infection and inflammation of the chorion and the amnion. Appendicitis. Appendicitis can cause preterm labor in the sense of the anatomical relation between the uterus and the appendix. Toxoplasmosis, malaria. These are systemic infections or maternal febrile illness. Toxic substances like smoking, alcohol, and cocaine. So what happens is in this group, the infections and toxoplasmosis, malaria, febrile illness, and toxic substances. This can cause a systemic inflammatory response, which we call SARS. So this causes maternal and fetal stress, which triggers the maternal fetal hypothalamic pituitary adrenal axis. Overdistension like polyhydramnios and multiple pregnancy. Multiple pregnancy is a fetal risk factor, but I just put it here for easier explanation. So what happens is that in polyhydramnios, there's a lot of amniotic fluid. This is amniotic fluid. So this causes pressure on the endometrium and the myometrium. So it causes stretching in the myometrium. Same as in twin pregnancy. If you have twins here, there will be overdistension of the myometrium. So if there's overdistension of the myometrium, there's overstretching of the myometrium. Now think about it like if you're pulling a rubber band, it has to go back to its normal shape. So this triggers myometrial contraction. Uterine abnormalities like cervical incompetence and uterine malformation. Now in cervical incompetence, this is cervical weakness. You can have a short cervix. Remember we said that the normal cervical length is about 2.5 centimeters to 3 centimeters. So anything less than this is a short cervix. It can be confirmed via transvaginal ultrasound. 2, you can have history of cervical biopsy or history of cervical trauma. So this causes premature cervical dilatation and effacement. Effacement is thinning of the uterus. So you have premature dilatation and thinning of the cervix. So this mucus plug will fall out here, and this can trigger preterm labor because the fetus will not be able to be retained by the cervix. Uterine malformation like in a biconjugate uterus. So the uterus is divided into two here. So you can have a fetus growing on one side of the uterus here. But as it grows and develops, the space here is too small to accommodate the fetus. So it starts to stretch on the myometrium. And remember what you said in polyhydramnios and multiple pregnancy, the rubber band theory. As it stretches on the myometrium, it increases the gap junctions. So this can trigger myometrial contractions. Medical illness like preeclampsia and chronic hypertension. Preeclampsia is hypertension in pregnancy. So remember in our video of preeclampsia, we said preeclampsia is an inflammatory condition that triggers inflammatory mediators like cytokines. So does hypertension. And preeclampsia and hypertension can cause uteroplacental insufficiency. This can cause fetal stress, which can result in activation of the fetal hypothalamic pituitary adrenal axis. Cardiac disease in pregnancy as well causes uteroplacental insufficiency, which can cause fetal stress, and in end result is the fetal hypothalamic adrenal axis being activated. Diabetes mellitus, where you have uncontrolled sugars, it becomes life-threatening for the mother. So you have to deliver the fetus regardless of the gestational age. This is elective induction of labor. This is also a cause of preterm labor. Either way, apart from the uncontrolled sugars, diabetes mellitus itself is a risk factor of spontaneous abortion. So if it happens after the age of viability, it can cause preterm labor. Severe anemia, where there's low hemoglobin, low red blood cells, so there's poor blood supply to the fetus. Nephritis is inflammation of the nephrons, which are the functional units of the kidney, so there's kidney dysfunction. Thyroid disease is a metabolic disorder which also results in uteroplacental insufficiency. So as you can see, these medical illnesses cause uteroplacental insufficiency, and some of them are inflammatory conditions which trigger in the inflammatory mediators like cytokines. So the fetus is in a toxic environment which causes stress. So it will trigger its fetal hypothalamic pituitary adrenal axis, to, which causes preterm labor. So it wants to come out of this toxic environment. Iatrogenic, meaning us doctors have caused the preterm labor. Abdominal operation for, let's say, appendicitis. This can cause maternal and fetal stress, which can also trigger the hypothalamic pituitary adrenal axis. Amniocentesis is where you produce a needle into the amniotic fluid, so you can actually rupture the fetal membranes, and also as you pass through the myometrium, this can actually trigger contraction. Induction of labor due to pregnancy complications like severe preeclampsia, uncontrolled diabetes mellitus, cardiac disease. So this medical condition can also cause preterm labor in the sense that it becomes life-threatening for the mother. So you have to deliver the baby regardless of the gestational age. Placental risk factors like placental abruption and placenta previa. Remember, placental abruption and placenta previa are antepartum hemorrhage. This is bleeding in pregnancy. So where there's bleeding, inflammation will kick in. So there's thrombin production, fibrin, inflammatory mediators like cytokines. Now, these inflammatory mediators, what they do is they trigger prostaglandin release from the endothelial cells. Once prostaglandin is released from the endothelial cells, there's a positive feedback. There's also prostaglandin release from the uterus and the placenta as well. So prostaglandin causes uterine contraction and cervical ripening. That is how preterm labor is triggered. Infarction and thrombosis is usually caused by hypertensive diseases like preeclampsia and chronic hypertension. So these cause uteroplacental insufficiency, which causes fetal stress, and then fetal stress will cause activation of the fetal hypothalamic pituitary adrenal axis. Fetal risk factors like multiple pregnancy, which causes overdistension of the uterus, intrauterine fetal demise that can cause disseminated intravascular coagulation, which is an inflammatory response, congenital malformation like in anencephaly can actually trigger preterm labor, and majority of the cases are idiopathic. Having talked about the risk factors, let's look at the etiopathogenesis. So we said some of the risk factors are medical illnesses, decidual hemorrhage like abruption, placenta, placenta previa, cervical weakness, overdistension caused by polyhydramnios, multiple pregnancy, inflammatory or infectious risk factors, iatrogenic. So as you can see, these risk factors activate the maternal and fetal hypothalamic pituitary adrenal axis. As you can see, there's a series of chain events where one thing triggers the other, another thing triggers the other. Whatever causes the maternal and fetal stress, be it medical illnesses, infectious causes, or abruption, placenta, or placenta previa, it activates the maternal and fetal hypothalamic pituitary adrenal axis. Now, these are two different axes, but they interact with each other. So, in the fetal hypothalamic pituitary adrenal axis, there's production of the adrenocorticotropic hormone by the anterior pituitary gland, which tells the adrenal gland to produce cortisol and also produce dehydroepiandrosterone sulfate, which is produced by the adrenal cortex. So this DHEAS tells the placenta to produce less progesterone and increase its production of estrogen. Remember we said progesterone inhibits myometrial contraction and also suppresses prostaglandin production. So in this case, it is reversed. There's decreased progesterone so that estrogen production increases. Now, estrogen increases production of prostaglandin and also upregulates the oxytocin receptors. Upregulation of the oxytocin receptor sends a positive feedback to the hypothalamus and tells the hypothalamus to produce a lot of oxytocin because there's now oxytocin receptors. So the hypothalamus produces oxytocin, which is released by the posterior pituitary gland. So prostaglandin causes cervical ripening as well as myometrial contractions. Oxytocin also causes myometrial contractions. As the events are occurring in the fetal hypothalamic pituitary adrenal axis, the maternal hypothalamic pituitary adrenal axis also triggers production of cortisol in addition to the cortisol that came from the fetal HPA axis. So the cortisol tells the hypothalamus to produce corticotropin releasing hormone. Now the corticotropin releasing hormone will trigger production of prostaglandin 1 or give a positive feedback to the fetal hypothalamic pituitary adrenal axis to also produce adrenocorticotropin hormone. So there's a cycle playing here that ends up in production of prostaglandin and oxytocin. Prostaglandin causes cervical ripening and also causes myometrial contractions. Iatrogenic and inflammatory or infectious causes also trigger the activation of the maternal and fetal hypothalamic pituitary adrenal axis. On the other hand, infectious causes itself or inflammatory causes itself trigger neutrophil and cytokine release like interleukin 1, interleukin 6, and interleukin 8. Neutrophils, interleukins, leukotrienes produce collagenase and matrix metalloproteinase. So what the collagenase and the matrix metalloproteinase do is they break down the collagen fibers in the amniotic sac and also trigger production of prostaglandin. So these effects of collagenase and matrix metalloproteinase causes rupture of the amniotic sac, which is called membrane rupture. And the interleukins neutrophils also trigger production of prostaglandin, which causes cervical ripening and causes myometrial contraction. Overdistension that occurs in polyhydramnios and multiple pregnancy causes increased mechanical stretch on the amniotic sac and also the myometrium. This causes increase in the gap junction, which triggers the release of cytokines. Cytokines in turn trigger release of prostaglandins. Now, because of the mechanical stretch on the amniotic sac, this causes membrane rupture. And because of the cytokines, there is prostaglandin release, which causes cervical ripening and can also cause contractions. In cervical weakness, we said there's premature cervical dilatation and premature cervical effacement. As the cervix stretches, it causes release of prostaglandin production. And also because the cervix stretches, it can also stretch the amniotic sac, which can cause premature rupture of membranes. Medical illnesses like severe preeclampsia and PROM as well can also trigger abruptio placenta, which can cause decidual hemorrhage. Once decidual hemorrhage occurs, there's formation of thrombin to stop the bleeding. Thrombin in turn triggers cytokine formation like tumor necrosis factor, interleukin 1, interleukin 6, which causes production of collagenase and increased matrix proteinase. So this production of collagenase and matrix metalloproteinase cause cervical ripening by production of prostaglandin and also can cause premature rupture of membranes. So how do you tell that preterm labor can occur in a patient or is occurring in a patient? Based on your clinical diagnosis, let's say there's a history of preterm labor, the patient has preterm labor before, has those high risk factors like infections, medical illnesses, multiple pregnancy, genital tract infections, and symptoms of preterm labor. By physical, we mean on your examination and investigations. You see the patient has having uterine contractions and the Bishop score is more than 4. The cervical length, if measured by the transvaginal ultrasound, is less than 2.5 centimeters. Biochemical, we mean the presence of fetal fibronectin in the cervical vaginal discharge between 24 to 34 weeks. In the previous video of prom, I mentioned that fetal fibronectin is a glue-like glycoprotein that binds the fetal membranes to the deciduum, to the endometrium. Normally, it is found in the cervical vaginal discharge before 22 weeks and again after 37 weeks of pregnancy. So, if you do a test of fetal fibronectin and the test is negative, it reassures that labor is not going to occur in the next 7 days. But if you find fetal fibronectin in the cervical vaginal discharge between, let's say, 24 to 34 weeks, it most likely tells you that preterm labor is going to occur in the next few days. So, any disruption that occurs between the deciduum and the chorion results in fetal fibronectin release. So, the the presence of fetal fibronectin tells you that preterm labor is most likely to occur. Like I have said, fetal fibronectin is not supposed to be found in the cervical vaginal discharge between 24 to 34 weeks. It's only found in the cervical vaginal discharge when the pregnancy is less than 22 weeks and when it's more than 37 weeks. Differential diagnosis of preterm labor. These are some of the conditions that mimic the symptoms of labor. So the patient might be having low abdominal pain, backache that can mimic symptoms of labor, yet they're just having maybe placental abruption, red degeneration of fibroids, acute cystitis, pyelonephritis, nephrolithiasis, these are kidney stones, appendicitis, gastroenteritis, and constipation. Investigations in preterm labor, you do a full blood count and differential count to see if there's any infection and to see if there's any anemia. You collect urine for urinalysis. You check for leukocytes, nitrites, and protein. If these are present, the patient most likely has a urinary tract infection. You also take the urine for microscopic culture and sensitivity to see what organism will grow there and which antibiotic it's sensitive to. Also collect a cervical vaginal swab and rectovaginal culture. Remember the organisms we talked about: bacterioids, ureaplasma, mycoplasma, group B streptococcus, group B streptococcus, and beta hemolytic streptococcus. All these can cause genital tract infections as well as urinary tract infections. Ultrasound for fetal well-being, cervical length to see where the placenta is, and also the estimated fetal weight and the gestational age, and if there is adequate amniotic fluid. Routine antenatal care tests like syphilis, hepatitis B, and blood typing. Management of preterm labor includes prevention of preterm labor, arresting preterm labor, appropriate management of the patient when she is in established labor, effective neonatal care of the neonate. Principles of management of preterm labor: you give steroids like betamethasone or dexamethasone depending on which is available. The benefits of giving steroids are that it reduces risk of respiratory distress syndrome, risk of intraventricular hemorrhage, and reduces risk of necrotizing enterocolitis, reduces risk of bronchopulmonary dysplasia. Remember that fetal lung maturity is complete by 34 weeks. So those who are less than 34 weeks gestational age at risk of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, and bronchopulmonary dysplasia. And also intrapartum transfer. You transfer the patient to a facility where there's a neonatal intensive care unit, and you give antibiotics like penicillin or erythromycin to prevent group B streptococcus. Remember, group B streptococcus causes a serious infection in the neonatal period, causing sepsis, meningitis, and pneumonia. Tocolytics are given to the mother to delay preterm labor, to give chance for steroids to work, and also for intrapartum transfer to a facility where there's a neonatal intensive care unit. You can also give magnesium sulfate. Magnesium sulfate is said to have neuroprotective effects in the sense that it reduces the risk of cerebral palsy, reduces the risk of intraventricular hemorrhage. Careful monitoring of labor to make sure that there's minimal trauma to the fetus and also make sure that the neonatologists are available during labor. Vaginal delivery is preferred unless otherwise. Cesarean is reserved for obstetric indications. What's involved in prevention of preterm labor? There's primary care. Primary care is aimed to reduce the high risk factors like infection, asymptomatic bacteriuria, preterm premature rupture of membranes, and cervical incompetence. So, where you suspect there's cervical incompetence, you can offer the patient a cervical cyclage, which is put between 14 to 24 weeks, maximum at 27 weeks. You can also offer vaginal progesterone or 17 alpha hydroxyprogesterone intramuscularly between 16 to 34 weeks. Remember that progesterone reduces myometrial contraction. Progesterone reduces myometrial contraction and also suppresses prostaglandin production. You can also give antibiotics in a patient who has preterm premature rupture of membranes and also genital tract infections. Secondary care of prevention of preterm labor includes screening tests for early detection and prophylactic treatment of preterm labor. You can offer the patient tocolytics like nifedipine. Commonly used tocolytics are nifedipine, which is the safest drug. You can give it between 24 to 30 weeks gestational age. And also you can give magnesium sulfate for 24 hours only if in established preterm labor or if the patient is planning on having a preterm labor due to complications of pregnancy. Tertiary care is aimed to reduce the perinatal morbidity and mortality by providing steroids. Measures to arrest preterm labor. This is like to delay preterm labor. You can only do this if the fetus is not compromised, the maternal condition is good, and the membranes are intact. The aim is to delay delivery for at least 48 hours, to give steroids, and also to provide in utero transfer to a facility where there's a neonatal intensive care unit. This involves bed rest for the patient, adequate hydration, antibiotics if you're suspecting infection, prophylactic cervical cyclage if they're less than 27 weeks gestational age, tocolytics like nifedipine, but these are almost not beneficial. They do almost nothing. And you can also give magnesium sulfate for neuroprotection. Now, contraindications to arrest preterm labor include maternal contraindications are severe hypertension, cardiac disease, antepartum hemorrhage, thyrotoxicosis, and gestational age of more than 34 weeks gestation age. This is because probably the fetal lung maturity has already occurred. So you suspect that there will be a good outcome of the fetus. Fetal contraindications include fetal distress, intrauterine fetal demise, and congenital malformations. Other contraindications include chorioamnitis, ruptured membranes, a cervical dilatation of more than 4 centimeters. Management of established preterm labor. The principles are to prevent birth asphyxia and also to prevent birth trauma. So avoid early rupture of membranes. Ideally, you're supposed to deliver the fetus with the membranes intact. Put an IV access with normal saline at maintenance rate to provide adequate hydration. You put the patient on IV penicillin for group B streptococcus prophylaxis and put the patient on steroids. Inform the neonatal intensive care unit that you're going to bring a preterm baby and also for the neonatologist to be there when during delivery. Birth should be gentle and slow. This is to prevent decompression and compression of the fetal head. And if the peritoneum is tight, you do an episiotomy. If there's poor maternal effort, you can use low forceps, but they are not routinely indicated. This is because they can cause trauma to the fetus. You do immediate cord clamping to prevent hypervolemia and hyperbilirubinemia in the fetus. Quick neonatal airway suctioning and transfer the baby to a NICU as soon as possible. Consider cesarean section if there's a breach or for other obstetric indications. Complications of preterm labor on the neonate. In the neonatal period, you can have respiratory distress syndrome, intraventricular hemorrhage, periventricular leukomalacia, necrotizing enterocolitis, persistent ductus arteriosus, neonatal sepsis, meningitis, and bronchopneumonia due to group B streptococcus. Short-term complications are retinopathy of prematurity, you can have feeding and growth difficulties and persistent infection and neurodevelopmental difficulties. Long-term complications include bronchopulmonary dysplasia, this is chronic lung disease, cerebral palsy, incomplete catch-up growth, and school difficulties and behavior problems. This is the end of our discussion on preterm labor. Where you're not clear, kindly put a comment in the comment box and I'll get back to you. In the next video, I'm going to talk about post-date. Please don't forget to subscribe to my channel. Thank you so much.